morning, everyone, and welcome to Breakfast at UMHealth. I'm Jaya from the Endocrine Unit, Department of Medicine, here in Faculty of Medicine. Today we are going to focus on a different kind of pandemic. There are some pandemics that we can overcome, and there are some pandemics that we cannot. And you are right. Today, the focus is going to be on the ever-progressive pandemic of obesity, overweight, diabetes, as well as metabolic syndrome, whatever you like to call it. So we as healthcare providers, of course, are given the task to actually not only treat our patients with this metabolic diseases, but also the onus is on us to be good role models in terms of providing a good role model aspect for our patients in terms of these metabolic disorders. So today we are actually going to mirror upon that. And to take us through that, we're actually going to look at the findings from the health screening that was done in last year's World Diabetes Day celebration, which was jointly organized by the Endocrine Unit as well as the Diabetes Care Unit here in UM. So these are going to be quite shocking revelations in terms of how are we doing in terms of our metabolic health. And of course, you know the routine, the Q&A. There will be a Q&A session at the end of this 20 minutes or so first presentation. And the Q&A should be put into the Q&A box, you know, the usual routine, and hopefully we can take some questions there. And to take us through what our health is like, the staff as well as some of the public who has been passionate about metabolic health. His passion really is into obesity, type 1 diabetes, as well as type 2 diabetes. And he has published several papers in diabetes as well. And he's going to take us through what the results are from the World Diabetes Day screening that was done here in UM last year. Quan, the Zoom is yours.
Morning, Prof. Jaya. Thank you very much for the kind introduction. Good morning, everyone. My name is Quan. I'm from the Endocrine Unit. And today I would like to present to you the results that we got from our World Diabetes Day 2022 screening. Of my talk, we'll go through about diabetes epidemiology and a worldwide scale, a regional scale, as well as our national data. And I'll briefly speak about importance of early detection and touch on what we did in the World Diabetes Day activities, our screening results, and last but not least, the implications of these results and any further plans that we should have. So we all know that diabetes is very prevalent and is arguably the biggest public health issue of the last and the current century, actually. So just how big is it? And we know that it's constantly increasing, and you can see worldwide the prevalence of diabetes is constantly increasing. At last count in 2021, according to the International Diabetes Federation Atlas 2021, 537 million adults globally are living with diabetes. But what's even more sobering is that about half of this global population with diabetes are actually living in this Western Pacific region, which is where we belong in this area of the WHO classification. So a huge proportion of the global population of diabetes is actually coming from our region. And it is projected to increase by 27% to reach about 260 million in the next 20 years or so. And what is more sobering is that actually a lot of our patients with diabetes are actually going around undiagnosed. And this is especially true in our Western Pacific region. As you can see, more than 50% of people living with diabetes are actually undiagnosed. Now, I believe this has got something to do with the resources available in our setting, as well as awareness about diabetes and screening. But I think this speaks a lot about our healthcare system and how we should be able to improve it. Now, because we know that resources may be limited in our setting, in many countries who may not have the resources to screen the entire population and treat their diabetes patients to an ideal target. So the WHO has actually come up with this initiative to unite stakeholders around goals of reducing diabetes risk and ensuring people who live with diabetes have equitable access to comprehensive, affordable care and prevention. Now, this is called the Global Diabetes Compact, of which our Associate Professor Dr. Lim Li Ling is also a part of it. So what targets have they set for countries around the world? So this is the minimum target that we should try to achieve in any population around the world. So the 5 targets that they've set is actually at least 80% of people living with diabetes should be diagnosed. Okay? They should be given a diagnosis so that they can then seek for treatment. We should also aim for 80% of people living with diabetes to have A1C of less than 8%, 80% to have blood pressure of less than 140/90, and more than 60%, 60% or more of people living with diabetes above 40 years old should be receiving statins, and all type 1 diabetes mellitus patients insulin glucometer. This is what we call the 80-80-80-60 targets that have been set by the Global Diabetes Compact. Now, what about the situation in Malaysia? We know, I think by now we've heard enough from our epidemiologists and our diabetologists about the prevalence of diabetes in Malaysia. We know that about 18.3%, about 1 in 5 Malaysians are actually living with diabetes. But what is very important in this data that we see is that more than about half of of people living with diabetes in Malaysia do not know that they have diabetes. About 8.9% out of 18.3 are actually living with diabetes unaware. And what is shocking is that if you look at the age breakdown, those people within the 30 to 39 age group, within the younger age group, a huge majority of these people who have diabetes in this age group actually do not know that they actually have diabetes. So in line with this, as part of our UMMC World Diabetes Day event in 2022, which was conducted on 14th to 17th of November 2022, it is an annual event in conjunction with the Global World Diabetes Day that falls on the 14th of November every year. The theme of our event last year was access to diabetes care, education to protect tomorrow. As part of this activity, we had free health screening, webinars, poster booths, as well as vaccination drives. So what we did for screening is we actually did screening tests with HbA1c, specifically a point of care test HbA1c. We used this Abbott Opinion 2 OCT point of care test HbA1c machine. And you may wonder whether how accurate is it, this point of care test HbA1c qualify as a screening tool. So it has been validated for use with capillary blood samples, and has been tested to have a 95.04% within the allowable total error of plus minus 6%, okay, and with a bias of HbA1c around 6.5% A1c, about negative 0.13%. And all these are within acceptable limits as approved by the FDA for screening purposes. So the results will be ready for within 5 minutes. Therefore, it's been deemed suitable for diagnostic as well as screening purposes. What were the criteria that we picked for our public to do the screening criteria? Of course, because the aim of this program was to actually screen for people who do not know that they have diabetes. So of course, we would not include people who have diabetes. So we screened all adults more than 18 years old and not known to have diabetes. So we collected other information, including random capillary glucose, their height, their weight, their waist circumference, as well as the family history of diabetes. Now, because this was a screening event, there was just a limited amount of information that we could collect. But we had very overwhelming response. Our target was actually to conduct the screening over a period of 4 days, but we had actually run out of strips by the end of the 3rd day, and we managed to screen a total of 745 people, of which around 500 were public and 200 over were staff from either UM or UMMC. Now, how do we define dysglycemia? So we go according to the Malaysian Type 2 Diabetes Mellitus CPG, targets, thresholds for diagnosing pre-diabetes as well as type 2 diabetes. So 5.7% of A1C to 6.3% to less than 6.3%, we will label them as pre-diabetes. And anybody with HbA1c of 6.3% and above are actually diagnosed, actually labeled as type 2 diabetes mellitus. Now you may wonder why. I think by now you've probably heard about recommendations of using HbA1c of 6.3% as a threshold for diagnosis of diabetes in Malaysia. And this actually differs from the global guideline of global threshold of 6.5% set by the WHO. Now, why is it? Actually, we look back into the literature. So there was this study in 2009, published in 2013, by Quan Hziung et al. They actually looked at a very representative sample of the Malaysian population. So they actually sampled about more than 4,000 people via systematic sampling across different states in Malaysia, of which they found about 3,800 people who were not known to have diabetes, and they took the HbA1c and then subjected them to OGTT. So when they compared the HbA1c versus the OGTT results, if they took the threshold of 6.5% as set by the WHO, we would actually underdiagnose diabetes mellitus by 8.7%, meaning the specificity of 98.1%, but the sensitivity of 36.7%. But if they lower the threshold of HbA1c to 6.3%, you actually increase the sensitivity to 42.5% and maintaining an acceptable specificity. So therefore, this is where the recommendation of HbA1c threshold of diagnosis of 6.3% in Malaysia came from. So we do have very robust local data to back up this recommendation. But what's very interesting as well when you look at this, the results from this paper is that in this study, the overall diabetes prevalence was 22.9%. And remember, this study was carried out in around 2009, 2012. So by that time already, they've already estimated the prevalence at 22.9%. But you note that about half of them are newly diagnosed, meaning they were not known to have diabetes at the point of time. And about 21.6%, meaning 1 in 5 of the study population were actually pre-diabetes. So what were the results of our screening results? So we screened a total of 745 people. So what we found is that a huge proportion, about more than 50% of our screening population were actually either overweight or obese, and more than about 53.7% actually had abdominal obesity. And we have a very high prevalence of family history of diabetes, first-degree family history of diabetes mellitus amongst our population. We screened about 225 UMHealth staff, and the rest were public. So of the entire screening population, we found that the prevalence of dysglycemia among the screening cohort was more than 50%. More than half are actually dysglycemic, and this includes either pre-diabetes or diabetes based off the HbA1c cutoffs that I have presented earlier. And we can see also that there's a general trend that the proportion of diabetes with dysglycemia actually increases with age. As we go across the age group from either 18 to 29, 30 to 39, 40 to 49, 50 to 59, and above 60 years old. So the proportion of both pre-diabetes as well as diabetes actually increases with age. And we looked at factors that are associated with dysglycemia, and not surprising, the first-degree family history of diabetes mellitus, abdominal obesity, as well as increase in age, are all predictive factors that are associated with dysglycemia status of either pre-diabetes or diabetes mellitus. And of these three factors, so these are all adjusted for sex and ethnicity already. And of these three factors, abdominal obesity is the strongest risk factor with odds ratio of 2.04 to predict dysglycemia. So when we look at each of these risk factors that have been identified and the prevalence of this glycemia among, if you have this risk factor, so amongst those who are aged more than 30 years and above, about 56.7% actually have dysglycemia. Those who have abdominal obesity, 61.6% have dysglycemia, and those with first-degree family history of diabetes mellitus, 62.5% have dysglycemia. But when you look at whether they have two risk factors, with abdominal obesity and age 30 and above, so the prevalence would increase to 66.6%. And if you have two factors, abdominal obesity with first-degree family history of diabetes, the prevalence increases to 63.7%. And if you're above 30 years old and above with a first-degree family history of diabetes, about 65.7% have diabetes, have dysglycemia. And if you have all three factors, 68.2% of those with all three risk factors actually have dysglycemia. So overall, the more risk factors that are present, the higher the prevalence of dysglycemia. Now, because this is a talk on breakfast in UMHealth, so we decided to zoom in to staff data. So we screened about 200 over staff, which were either University of Malaya staff or PPUM staff. So when you look at the staff data, the pattern is not much different compared to the general population we saw before. But we do see an even higher rate of overweight and obesity amongst our staff, especially as well as abdominal obesity. So the prevalence of dysglycemia amongst UM and UMC staff, okay, is even higher than general population. Okay, so we have more than 56% of UM and UMC staff that were screened were either pre-diabetes or diabetes. So do you have to remember that these were people who did not know that they were living with dysglycemia before this. So if we divide them into age group, again, we see that the prevalence of dysglycemia increases with age. However, the most newly diagnosed pre-DM/DM by numbers were actually within the 30 to 39 age group. And this is very important because young onset diabetes is associated with higher chances of complications in the long run. Now, if we divide them into BMI categories, not surprising that most newly diagnosed people with pre-diabetes as well as diabetes are within the obese category. And we noticed that the threshold for a diagnosis of obesity that we took here are actually based off the newest recommendations in Malaysia of cutoff for diagnosis of overweight and obesity. So the current recommendation of overweight is actually 23 kilograms per meter square, and obesity to be 25 kilograms per meter square and above. Now, if we look at the data based on gender, we notice that, of course, the rates of these pre-diabetes and diabetes are higher among men. But overall, this reflects a pattern that among staff, more women than men actually came forward for screening. You can see the overall numbers of women who came for screening were actually higher. But of the men who came for screening, a larger proportion actually had pre-diabetes. So what were the follow-up plans that we did after the screening activity? So anybody who were newly diagnosed with type 2 diabetes or had an A1C of 6.3% and above were referred to be seen at our diabetes care unit, diabetes prevention clinic at Menara Selatan. And people with pre-diabetes with the A1C within the pre-diabetes range were referred for repeat testing of either HbA1c or OGTT. But what we found was that there was a very high dropout rate. We had 95 patients who made appointments for follow-up, but only 36 have turned up so far. This is a combination of factor of poor compliance to follow-up as well as our limitations in our manpower follow-up as well. Now, having said that and having seen all that data, we have to take into account why is it that pre-diabetes, should we take it seriously? I mean, pre-diabetes, even though the name suggests that it is not something, it is not conventionally considered as a disease, it is not to be taken lightly, because we know that the rate of progression of pre-diabetes to type 2 diabetes is actually 5 to 10% annually. And 70% of individuals with pre-diabetes will develop diabetes throughout their lifetime, with a greater risk for those who are overweight or obese. And pre-diabetes is broadly associated with traditional diabetes complications. So meaning by the time you are pre-diabetic, your risk factors of coronary artery disease as well as retinopathy is already increased. And this risk for coronary artery disease has been causally associated with pre-diabetes. So what does this mean for us? We now know that, we already know that a large proportion of Malaysians, and now we know amongst our healthcare workers as well, have an increasing age, obesity, and family history are very strong risk factors. And a high proportion of young adults among 30 to 39 years old have dysglycemia. And those who detected pre-diabetes should have follow-up assessment of either OGTT or repeat HbA1c. So if any among you in the audience have come forward for the screening and you were told to have an abnormal HbA1c and you did not come for follow-up, I would strongly advise you to go ahead and compare and further go for further reassessment of whether you have progressed or you still have pre-diabetes. Now, what do we hope to do next? We do hope to establish a multidisciplinary effort amongst our primary care staff, our staff health, within our endocrinology unit, our diabetes care unit, as well as our public health, to coordinate regular screening efforts for both public and staff. Now, to do that, we of course also need to increase capacity for follow-up care, because we did notice that by the time if we start diagnosing more and more diabetes patients or pre-diabetes, now what do we do with these patients? Because we need the capacity to start seeing these patients and care for them as well. We need to do early screening of complications for people with pre-diabetes. And also we should establish a service for newly diagnosed diabetes for early intensive treatment. Now, to do all this, we need more resources. Now, last but not least, this is just a plug for my study. If you are concerned about your metabolic health after listening to this talk, please come and join our study. We are doing a study on metabolic healthy obesity. So if you are a healthcare worker in UMC and you're healthy, you're not diagnosed with any medical illness, and you know that you have a body mass index of 23 kilograms per square number, come and contact either Dr. Deva or me. So part of this study, you will have your body composition analysis and several blood tests done. That concludes my talk today. But before I end, I just really want to give a shout out to the entire World Diabetes Day 2022 team and the endocrinology team who has made this event very successful. And we hope to carry on this activity again within the subsequent years, because we believe it will benefit a lot of people. Thank you very much. Over to you, Prof. Jeyakantha.
Thank you very much, Quan for that very enlightening description on how our own metabolic health is like. It's quite embarrassing, I must say, that the prevalence of being overweight and obese is actually been in our own MCUM populations actually probably higher than the general Malaysian population. So there are several questions, Quan I think we should answer them. There's a quick one on what should we do with pre-diabetes? Is there any intervention to prevent progression to diabetes?
So yes, if you were diagnosed with pre-diabetes, so remember that this HbA1c point of care test is actually validated for diagnosing diabetes around A1c about 6.5%. So we don't really know whether the A1c of between 5.7 to 6.3 are very accurate. So if you have the A1c of within the pre-diabetes range, you should go for reassessment, repeat HbA1c, okay, and possibly even do a OGTT to check whether why is it that you are within the pre-diabetes range. So meaning either you are glucose range or in fact glucose glucose or post-meal glucose that is high. So if you are truly within the pre-diabetes range, so we know that treatment has been shown to be beneficial. And this includes both lifestyle modifications, reducing weight and improving metabolic health. And there are medications, including metformin, that's been shown to have provide benefits for people within the pre-diabetes range.
Yeah, I think I agree with you. Predominantly, it'll be a lot of lifestyle change that's required. There's also a question on in terms of the accuracy. I mean, or is there any caveats that we should worry about when you use? I know you did show us the sort of the accuracy of the POCT A1C, but is there any caveats or not? Like, I mean, in certain people, I mean, in terms of using A1C.
Yes, definitely. So, of note, actually, the Malaysian clinical practice guideline do not recommend pre-OCT HbA1c as a diagnostic tool for diabetes because of concerns about accuracy. But overall, it is still a very good screening tool. But HbA1c on its own, whether POCT or whether to the lab, the main caveats for it is if people with either anemia or hemoglobinopathies or hemoglobin anomalies would have inaccurate or falsely raised or falsely low HbA1c. So, and in our local setting, with the rate of thalassemia and hemoglobinopathies to be quite high compared to the rest of the world, so this is actually a very legit concern, and that should be taken into account when we interpret the HbA1c.
Yeah, sure. Anemia, hemoglobinopathies. There's also a question on how many of those who went for OGTT, Quan Hziung actually had confirmed diabetes or pre-diabetes. I mean, the follow-up study.
We don't have a collation of the entire people who come up for repeat OGTT per se. Because repeat OGTT, we have please send them to primary care. We don't have the data on follow-up yet. But those who were actually within the diabetic range were seen with us in the diabetes care unit. And if the A1C were actually more than 6.3% and they have symptoms, we actually do not repeat OGTT and we just treat them as diabetes.
Sure. There's a question, Quan Hziung, on how can staff go and screen themselves? I mean, UMMC or what is the pathway?
I mean, for now, this was a screening drive. Therefore, it was we did it as an open drive for everybody. Of course, if you are concerned, I mean, staff health is always an option. Okay, I hope the staff health people will not going to curse me for sending people that way. But of course, if you're concerned about metabolic health, staff health is always an option. And feel free to join my study as well. We will be doing HbA1c testing. If you're not known to have diabetes, you can contact me on.
Yeah, no, I mean, I'm sure staff, I think it's very, very important because you have showed us what the implications are. I mean, what the situation is like. And I think having bad metabolic health among staff also will be bad for the university and the hospital, because probably in some sense it should be maybe our metabolic health should be included into KPI. Then maybe we'll all get up a bit more and not just sit in front of our laptops or in our clinics all the time. Okay, Quan Hziung, I think maybe there's one last question. And is there any initiatives to prevent or pre-diabetes as well as obesity amongst our amongst our workers, our staff here in the hospital, by the hospital or by the university?
I think the initiatives are there. As far as I know, our obesity services is in the midst of being set up, and we do hope to start rolling out amongst staff first before we roll out to the public, and mainly it's limited by the resources that we have. But also I know that the sport medicine units also already doing certain initiatives to help staff with these to lose weight. And these are all initiatives that are there, and it's really about raising the awareness amongst our staff as well to start looking out for this kind of initiatives for them to participate in.
Yeah, thank you very much. I think I just want to summarize to say that, I mean, I guess I hope this was really a wake-up call for all of us. I think definitely it was for me. I have to really look at my own metabolic health seriously. And it's no laughing matter that among us healthcare workers, the prevalence of being overweight and obese is high. 2/3 of us are either overweight or obese. And there are initiatives. Please do keep your radar on. The hospital as well as the university are embarking on multiple initiatives to improve metabolic health, to reduce our staff weight and improve their overall health. Thank you very much, Dr. Lim Quan Hziung. I know there are many other questions, a lot of interest in this, but I suppose can meet up with us in the unit, diabetes care unit, as well as endocrine unit in the future. So I think time's up for the first session, and I'll pass over to Dr. Nisha, who will chair the second part from the oncology department. Thank you very much, everyone.